Good? Not too bad? How was yours, Janet? It was okay. Good. Well, nice to see you this morning. So good morning, everybody. Happy Saturday. It's the weekend. Welcome. My name is Jennifer Ahern. I am the Chief Officer and Permanent Secretary in the Ministry of Health, and I'm extremely excited to be back here again for what, unfortunately, is the final day of our conference. Have you guys been here through the whole conference? Yeah? How have you enjoyed it? Good? Excellent. That's great. And how was your breakfast? Did you all get some breakfast? Did you steer clear of the sodium? I'm looking at Marcia. Nobody had any sodium with their breakfast or extra sodium with their breakfast this morning, I hope. All right. Well, a huge thank you to Baptist, who are our sponsors for breakfast. Let's give them a round of applause. Just a little bit of an announcement. I have somebody's keys up here. They were found near the hospice booth. So they have a tag that says, "Here's to your health," and a little leather fob, a Honda thing. Are they you? There you go. Nope, not you. Okay. All right. Well, if anybody's looking for their keys, a little red cap, I have them. And I know you won't get very far without them, so you can come and let me know if they're yours. All right, so good morning. Councillor McTaggart is here, but I don't think he's made it in from breakfast, so welcome to him. A huge thank you to Tenet Healthcare. They've continued to support the conference as our Premium Plus sponsor, and we couldn't do it without them. Can I get a round of applause for Tenet? And of course, Iron Shore Pharmaceuticals, who provided sponsorship for our cocktail reception on Thursday night. That was great as well. Big round of applause for Iron Shore. Also our premium sponsors, the Health Services Authority, DART, BAF Insurance, and Tower. Okay, so have you all got your flu shots? Yes? No? Did you get your health check? Yes? So the health check is at the end of the hall. The flu shots are next door. You can also sign up next door for the MyHSA patient portal. Make sure you do that. And if you forgot to charge your phone last night because you were having such a good night, Tower's got a charging station just outside the door, so be sure to visit that as well. Good morning, Councillor McTaggart. Thank you for joining us today. So ladies and gentlemen, here we are, the last day. Again, just a reminder, Generali has sponsored our Wi-Fi. The password is Generali, lowercase, G-E-N-E-R-A-L-I, so you can get online there. And on the topic of phones, please take a second, make sure your phone is either off, on silent, or vibrate. We don't want to interrupt or disturb any of the speakers or your fellow delegates. There are so many exhibitors this year. I hope you've all had a chance to go and visit them. We're really grateful for their support. I've seen some really fun giveaways as well. So this is your last chance today. If you haven't done so already, please make sure to go do the rounds. And don't forget also, as I mentioned, you want to go get your flu shot from the Health Services Authority booth or sign up for the MyHSA patient portal. The other thing that we really encourage and actually really want you to do is to make sure that you give us some feedback on the conference. We do have some evaluation forms that will be available. You'll also get an email after the conference, so you can also do it online. But really, just when you get the email or before you leave today, please do give us your feedback. It really helps us to plan next year's conference, which we hope will be as much fun as this one has been. All right, and your CME certificates are available as well. So big thanks to all of the sponsors. Cayman Airways, they were very kind in providing the airfare for our Cayman BRAC delegates. Got any of the BRACers in the room? BRACers in the house? Yeah? All right. Welcome. Hope you've enjoyed the conference. And Cayman Airways will also be giving away 2,500 frequent flyer miles to 2 lucky delegates. Ooh. Can I get an ooh? Ooh. All right. Yeah, it would be great. You could come back and visit. How about that? All right, so let's get started. We've got some great speakers again today, so really looking forward to hearing from all of them. Our first speaker this morning is Dr. Jim Cleary. He's the Associate Professor of Medicine at the University of Wisconsin School of Medicine and Public Health, and he's a physician with a palliative care program at UW Health. After graduating from the University of Adelaide Medical School, South Australia, Dr. Cleary trained in internal medicine and medical oncology at the Royal Adelaide Hospital and then undertook 3 years of opioid pharmacology research. Moving to the UW in 1994, he developed a palliative care program from which he has recently stepped aside as medical director. Throughout, he has served as program director of cancer control at the UW Carbone Cancer Center with full integration of palliative care. He was the 2004 president of the American Academy of Hospice and Palliative Medicine. He serves as a North American editor of Palliative Medicine, the research journal of the European Association of Palliative Care. He has global connections in cancer pain and palliative care, evidenced by the releases of the recent Global Opioid Policy Initiative publications for Africa, Asia, the Caribbean, and Latin America, India, and the Middle East. His current grant funding is from the National Cancer Centers Institute's Global Health Program that is supporting a fourth African cohort of the PPSG's Pain Policy Fellowship. Dr. Cleary is a member of the World Health Organization Working Group for Palliative Care and the HGEI Lancet Commission on Palliative Care. Dr. Cleary is also an avid cyclist, and I learned last night that earlier this year he cycled across Wisconsin. Yeah, so ladies and gentlemen, please join me in welcoming Dr. Cleary.
Thank you, Jennifer. Yes, it was 175 miles in a day, and I'm still recovering. My goal today is to, there we go. I'll go back one. And I've changed things up a little bit because I've been delighted with the innovation of this program. I thought the opening night speech on the architecture and planning was stunning, and the speeches again yesterday being provocative. So rather than just palliative care, I've questioned, should we talk about the concept of healthy dying? And it's an interesting concept as you move forward. I have no conflicts of interest of significance to report from industry. These are all my handles, you name it, whatever, email, Facebook. But I'll actually be tweeting during this talk. And if you follow the hashtag HPM Global, links to many of the things that I will be referring to will actually be available and sent to your handheld on Twitter. So sign up for Twitter if you haven't, and the hashtag is HPM Global. You last year focused on non-communicable diseases, and I want to bring that forward, and recognizing that approximately 60% of all deaths will eventually, by 2020, will actually be from non-communicable diseases. And 80% of these will be in low and middle income countries. You can see the diseases, you can see the risk factors that are making up the non-communicable diseases. And palliative care has become a very important part of this. But I want to ask the question, what are we doing in medicine? And I am a medical oncologist, and what are we actually doing in cancer medicine? We so often hear the language, if it's not palliative, it's curative, or it's not curative, it's palliative. It's this stark contrast between curative and palliative. And here is a tweet from, I can't say a colleague. We were talking about having discussions, end-of-life discussions, and here's an oncologist. Easy to say, but as an oncologist, my role is as a warrior against death. Pretty strong language. End-of-life discussions, completely different role. And if we even look here, and this is to show you we're up to date, this morning's JAMA Network headlines, they've got the trends in the US mortality. But there's a new letter in JAMA which actually looks at the use of superlatives in cancer research. We consistently use words like game changer, revolutionary, even though we have no data to support the fact that they're game changers, but they sell newspaper headlines, Time magazine headlines, and they get funding. So what are we doing in medicine? This is a survival curve. The blue line represents the survival rate of the normal population, and the black line, a disease. We've got years along the x-axis and percentage survival on the y-axis. But let me just remind you, the world death rate is holding steady at 100%. This is from The Onion, but it's very significant. There is a lot of upset, the fact that despite all the resources that have been put into medicine, the death rate has not budged. So what is a cure? I don't talk to individuals about being cured. A disease is curable if people who get that disease don't die of the disease. Wendy Lapham is a medical oncologist who has low-grade lymphoma, and she actually says she doesn't want to know she's cured of a lymphoma because she'd have to die of something else. So she's very comfortable living with her chronic disease. but a disease is curable. Much of what we do in oncology, and in fact all of medicine, is work on prolonging survival. And I would even say that we don't save lives, but that's the magic words we use, life-saving therapies. They're death-delaying therapies. We're postponing death. But can you see the headline of Time magazine or the local paper? New death-delaying therapy. But increasingly, WHO and even the American Cancer Society is using language of avoiding preventable deaths. And we have to be very careful with the language that we use. But again, a lot of what we do has no impact on survival, particularly people with very advanced disease and people with comorbidities. Once you have multiple diseases, COPD, heart failure, and you get cancer, really what we're doing is focusing on palliative care and having very little impact on survival at all. And I love this one. I'm not sure if it's a Bush, George W., but I knew this would happen. Do I want to be remembered as a chemotherapist or radiotherapist or as a carer of people living with cancer? People don't care about what you know unless they know you care. Very, very important as we move forward with our overall health care. I'm going to present a case, I don't like the word case. Here's a clinical situation, a story. Mrs. MB, an 86-year-old woman, she's diagnosed with endometrial cancer with bone metastases. 3 weeks later, she has a small stroke, we think. She has a fall, she breaks a hip. What should we do? Repair the hip or keep her comfortable with opioids and get hospice involved? And that's a question I'm actually just going to leave with you to contemplate as I present some of this information. But palliative care and the palliative care pizza here, we yes very much focus on the physical, but adding and building these very important components, the psychosocial, the social, the psychological, the social, the spiritual and existential. And again, I'll use the words that I do spend some time talking to people about spiritual issues. Sorry, not talking to, talking with people about their spiritual issues. Too often physicians talk to rather than actually listening. And my wife's in the audience and she'll agree that that's something I might do at work, but I don't necessarily do at home. Improving palliative care for cancer, and this is a link that I've tweeted out, was a significant document for me in 2001 because it talked about what the skills that make up palliative care. Most of us see palliative care as just care of the imminently dying, but it really is bringing in all these issues such as communication, advanced care planning, symptom relationships, and you can look at it this way, the essential building blocks, the communication, advanced care planning and psychosocial issues, building on symptoms, and it does actually ultimately lead to better care of the dying. This is a platform that many of us use for communication. Spikes. It's not a protocol, it's not a script. But look at the setting. Do you realize patients think you spend more time in the room if you sit down? And in these days of patient satisfaction, why wouldn't anyone sit down in the room? Because they then think you spend longer. But the perception, what is their understanding of the situation? The invitation, what do they want to know? Or is it in fact an elderly woman says, no, don't talk to me, talk to my son. But that's her right to do that. There may be some cultural things caught up in it where just because her son's in the room, she has to say that, and she really would like to know. But K is knowledge, sharing the news. E is empathy, and S is strategy. So using this platform, and you can change the order around a little bit, but it doesn't spell spikes if you change the order around, which is why it's in this order. But one of my colleagues, this is an expression my father said, if you tell the truth, you don't have to remember what you said. And it's actually very, very truthful. Toby Campbell, one of my colleagues, is using some research that we actually gathered during some NCI cancer communication studies where we taped oncologist interviews. And this project is called Oncobabble because very much what happens in the patient room is unknown, but our perception is we don't really know what's going on and we're not good at communication. So very complex. This is a detail, but what they do is they have sociologists go through and analyze the transcripts, and this is what it looks like. So you have a patient who's, the caregiver says, how does the scan look? It looked great. Oh, but the scan looked great and very stable, very stable. So you're sort of on right track and we'll keep you doing what we're doing. So you're starting your 14th month. Beautiful thing, lovely reinforcement, cheerleading. This is beautiful now. The fact that we're using the words, and then we go on, and what did we do about the prescription? Anything? So that's one discussion. That's not too bad. Here's a breaking bad news one, delivery of scan results. There's an interpreter involved, which may make it a little more complex. On the scans, unfortunately, I think that this chemo that you've been on has probably done as much as it's going to do. We're not seeing any further improvement, says the caregiver. In fact, we're seeing some new areas of disease in the liver come up since the last scan. So I think that tells us that you've probably gotten as much benefit as you're going to get from this treatment. And in 0.8 seconds, 0.8 seconds, and then another 1.3 seconds. So just on 2 seconds, the good news, there's lots of options here. We've got a lot of other chemotherapy options available, although there's no guarantee that any will work. Of course, you know they've a lot to choose from, and there's a good chance that we will see some response. This is a breaking bad news discussion in a major US cancer center. We did not record a single act of empathy from an oncologist in our major centres. No silence, no acknowledgement that this may be difficult news. Do we even know that the patients had a chance to absorb this news? But we've gone on already talking about treatment, and this is becoming an increasing focus of our research at the moment. We also did some research of what do we actually do in inpatient medical oncology. And this was a study done by Lisa Illig, and I'm going to show you 2 studies, 2012 and then some 10 years later. But what Lisa did was actually say, people who get admitted to medical oncology don't seem to do too well. So here's the population: lung cancer, GI, breast, genitourinary, and a spread of other tumours as well. We had 151 patients who were admitted 191 times. The average or the median length of stay was only 3 days. And 87% of them had metastatic disease. Median survival, 4.7 months. The 12-month survival was 25%. Now, many of you are sitting there saying, well, I'm going to Mayo Clinic rather than the University of Wisconsin if that's your survival rates, with Mayo Clinic just down the road. But that was actually similar data to what we see now across the whole of the United States for inpatient medical oncology. And this just divides up the different disease groups. Green is lung cancer, the purple is GI, breast yellow, GU is the blue, and the others, which is lymphomas and head and neck at that stage, is actually the red line. And somewhat ironically, I was the guy who was responsible for the people in the red line, even though I was the palliative care physician, and it was my patients who were surviving longest. Tom talked about some of that yesterday. Life on B66, this was an updated version of the same study. This was the 2000 data, the 2010 data. Again, very similar disease groups. If we look at it, some more sarcomas, because we had a physician come on who loved giving toxic chemotherapy to people with sarcoma. And this is why they were admitted. 66, 2/3 admitted because of symptoms, and you can see the other causes. And the symptoms that they came in with, 43% came in with pain, GI toxicity, shortness of breath. This is what was happening. And our overall survivals, almost identical to 2000. Median survival in the order of 3 months. So one of the things, and Tom talked about this outcome and how at Hopkins they're actually seeing hospice referrals go up. We saw oncologists were not having this, they had the discussion, but they still weren't discharging people to hospice, despite the fact that they had a short time to live. And it was recommended, but it was only happening in about 1 in 5 patients. So we need to look at this transition. And one of the issues is very much conceptually, we see hospice, we have seen hospice as throwing people over the wall. There's nothing else we can do for you is some of the language we use. Who wants nothing care? But the doc, there's nothing else I can do for you. And even when I've sugarcoated it and said, well, we have palliative care, very nice, I've had feedback from families and heard them say, the day the doctor told us there was nothing else they could do. And I say, I didn't say that. I told you all about hospice. But they hear, nothing else left to do. And just because I am a medical oncologist and I want to pick on the cancer surgeons a little bit, I'm not a surgeon. We'll talk about the surgeons, but this is a lovely study done by one of our chief residents a number of years ago. It is older. She has published it, but David Marvey, now at Northwestern, Sharon Weber, still the head of our oncological surgery. But they looked at bowel obstruction. None of us like managing bowel obstructions, malignant bowel obstructions. And the problem was, as Colette looked at this, she actually said, it's management by committee, and I don't think we're really telling these people the truth. So she looked at the survival data for these tumours, and you can see colorectal, there's a number of GYN tumours, and then a scattering of others. Median survival, 3 months. And again, you're saying, I'm going to Mayo, not the University of Wisconsin. I'll come down to Miami, it'd be much better. But if we actually look at these, it didn't matter whether they had surgery or conservative medical management in terms of their overall survival. And the surgeons suddenly sat up and said, wow. And the surgeons are particularly concerned because of their 30-day mortality rates. They don't like people dying within 30 days of an operation. You get dinged for that. Is that right, Adrian? That's correct. So the last thing you want to do is operate on someone who's going to die in 30 days. They changed their practice. The significant finding, and I think it's very important, was if you had a disease-free interval of greater than a year, meaning your last known disease was greater than a year, these people did better. But if this bowel obstruction had come up within months of your diagnosis, doing surgery didn't make a difference. There were some issues of outcome in terms of oral intake, which we could spend time looking at, but in actual fact, putting in a venting feeding tube and allowing people to eat and drink may actually be a very comforting measure for them. And by venting G-tube, this is a big enough tube so they can turn on a tap on and off when they get obstruction. It's a great way. Eat and drink what you like and then just turn on the tap. They can't eat a steak because that'll tend to get stuck in the tube on the way out, but it's not what you like. But we're moving more and more to this model. And I think this is a significant model change as we go forward to actually say, hey, let's look at integrating palliative care from the point of diagnosis. We have hospice in there in the light grey and the black in terms of bereavement support, but it's really looking at the spread across and not just saying that this is throwing people over the wall. Tom spent some time talking about the studies that actually show improved survival in palliative care. Yes, the Temmel study is fine, but I worry that we're getting caught up in what I term the industrial medical complex if we just focus on survival. It's not just about survival. It is about quality of life, and we need to make sure that it's not just focused on this issue of, well, we got you 3 more months. We may have just got you 3 more months of suffering. And that is one of the terms and the issues I will often discuss with families is the issue of suffering. Sometimes in our effort to buy more time, all we end up doing is buying more suffering. We don't want Dad to suffer. And it's not just cancer. Dementia, the issues with feeding tubes, cardiac disease, still a leading cause of death, many situations, and increasingly pediatric issues as they come forward. And this is a paper from the early 90s looking at how we can integrate palliative care into the whole heart failure situation now, particularly given when we've got transplants, which suddenly at point 4, when the heart becomes available, goes back to the very beginning of care and creates a whole other new disease. So looking at these issues, and I'm going to focus a little bit on symptoms now, and symptoms either from disease and therapy, from the disease and from therapy, but particularly looking at pain. And I'm also going to address the global issues. And I know the Caribbean never really comes up as big as it should. You need to get some bigger islands. But it's really showing where the palliative care is located in around the world at the present time. The green is those countries that have good integration, moving down to the yellow where there is absolutely no activity. And most of us understand why Greenland has no activity, because there's no one there. But this is morphine consumption around the world. And the WHO Collaborating Centre that I lead gets this data from the International Narcotic Control Board. And we see that most of the world's population actually has no access to pain relief. And here's a clinical example.
Here, in the rural outskirts of Calcutta, India, top-notch medical care is hard to come by.
Key tablet, Bios.
But Dr. Abhijit Dam makes do. The day we met him, he had transformed this school courtyard into a makeshift clinic and virtual pharmacy, dispensing drugs for a variety of ailments. But when he heard reports of a woman dying of breast cancer in a neighboring village, Dr. Dam knew he was in for a challenge. The woman, named Fatima, had a massive breast tumor, clearly infected and clearly painful.
She has severe pain. She can't sleep at night.
Fatima's family says she screams in agony day and night. But because of strict narcotics laws, morphine, the gold standard in pain treatment, is nearly impossible to get in most of India. So Dr. Dam is forced to improvise with readily available analgesics.
This is really difficult to watch, and it's particularly difficult considering that, with a 2 rupee medication, she would not be screaming.
I still find every time I watch that, the cry to be quite piercing. It really brings into context the nature of the suffering that our patients go through. But let's look back on the history of opioids. Opium has been around since the dawn of time, as far as we know, with poppies. But morphine was discovered in 1811, and we actually saw it becoming popular, or much more popular, during the Civil War with the advent of the hypodermic syringe, the US Civil War. And that's what really allowed morphine to be produced at that time. We see here the first home for the dying was established in 1842 in Lyon, Paris. And that was a significant finding. It moved to, in Lyon, France, moving to Paris in 1875. And note, Calvary Hospice in New York started in 1899. Hospice is not that new. It's been around for many, many years. And we'll talk more about how it changed. Heroin introduced as an analgesic and cough suppressant in 1874 and brought to the United States by Bayer Pharmaceuticals, the makers of aspirin. Oxycodone, discovered, synthesized in Germany in 1916. And around this time, there was a feeling that alcohol was actually more of a problem than opioid. But in 1915, the Harrison Act came out in the United States, and then the Dangerous Drug Act. Some 25,000 MDs were on narcotic charges for prescribing, and 3,000 actually went to jail. During World War II, there was no addiction because of the situation in Burma with the Japanese occupation. But really, addiction, dependency syndrome actually grew up in the poorer areas of the United States after that. We see also the advent of different medicines. You can see hydrocodone, pethidine, 1932, a belief that it was an antispasmodic, but it's not really. I got taught that you had to use pethidine for gallbladder disease, cholecystitis, and it doesn't matter. The studies were done on the cat sphincter of Oddi, and you actually need to do it on the opossum sphincter of Oddi, because that's one that's like humans. Methadone, synthesized in 1938, and the Dolorphin actually comes from the German N-pain. But then we have evidence of Mother Teresa doing her work in Calcutta, beginning to turn attention to the end-of-life care. We have Dame Cecily Saunders, who was a nurse, social worker, and physician, who actually documented that the regular use of morphine really made a difference to people's cancer pain. And here I had the honour to present her with a Lifetime Achievement Award from the Academy of Hospice and Palliative Medicine. You can see she has a sleeve on. She actually suffered from lymphedema related to breast cancer, and she was actually quite responsible for St. Christopher's having a lymphedema clinic. so that not just the dying came there, people came for rehab, came for lymphedema care at the same time. If we look at 1960, fentanyl was discovered by Paul Janssen, and this was a significant advance forward, and many of us are aware of that through the fentanyl patch. But 1961 becomes critical because the Single Convention on Narcotic Drugs was brought out by the UN. And this was to prevent abuse and diversion and ensure the availability of drugs for medical purposes. I'm using the word drugs because that's in the Single Convention. The WHO would encourage us not to use the word drugs when we're talking about medical issues. They're medicines. Drugs are those other things. The drug problem. There may be a problem with some of the medicines we use, but let's use the concept medicines. The medical use of narcotic medicines continues to be indispensable for relief of pain and suffering. Adequate provision must be made to ensure their availability. Bao Mount is a surgeon from Canada, Montreal, and because of problems with the concept of hospice in French, he actually came up with the term palliative care. And the reason I raise Bao's story is because he did, as part of his career, a comparative study of oral morphine versus the Brompton cocktail. Brompton cocktail discovered in 1893, and that's what we were using as our standard medical care in the 1980s for cancer pain. We had not advanced. 90-year-old technology. We seem to be less scared of the Brompton cocktail. The WHO Essential Medicines List was established in 1977, and morphine and codeine were included in this. And I put an essential medicine should be at a price the individual and the community can afford. And that's a critical part of essential medicines. This is a picture of my mother and father. They actually argue over who got me involved in this work. My mother was a hospice nurse. My mother was a physician. But in my medical career, she gave the first dose of oral morphine at a hospice in South Australia. And they stood round after giving 10 milligrams of oral morphine, hoping that the patient would keep breathing. And we now know that that was the fear that existed at that time. Really quite significant. She spent some time at St. Christopher's. The WHO ladder, what you're seeing on the bottom in these graphs is actually opioid consumption curves for 3 countries. I've actually got the United States, Australia, and Germany up here. And the size of the bubble reflects the population. US in blue, Australia in gold. Green and gold is playing today. If you're following the rugby against those nasty All Blacks. Germany in green. So the WHO pain ladder came out. Here we actually have the Wisconsin Cancer Pain Initiative that was established in the 70s. And why it was established was because they were actually asked to look at heroin for pain relief. And what they showed with support of different government programs was that you could actually increase the use of morphine, and there was no increase in crime associated with that in the United States, in Wisconsin. And it really led to saying, let's improve access to morphine for cancer pain patients across the US. And there were major problems. This is Charlie Cleland's work from the Eastern Cooperative Oncology Group, major cancer centers in the United States. 42% of US cancer patients were undertreated, and if you're an older minority woman, you were less likely to be treated. And some of the worst treated were the immigrant women living in Miami or south of Miami. We really showed at the Dade County Hospital that there was really a dramatic undertreatment of pain in those issues and a lot of logistical issues in order for people to get pain medicines. The group, Pain Policy Studies Group, was formed in 1996, and we can now start seeing opioid consumption bumping up in the United States and Australia. MS Contin was marketed then, as was Cadian in Australia, to sustained release morphine products. So the impact of industry, pharmaceutical industry, is significant in this process. Achieving Balance was written in Madison, Wisconsin, a WHO document in 2000. Which has really been a principle. And we can see again another bump in the US consumption, and this is when OxyContin was released to the market in the United States. For this concept of balance, national policy should establish a drug control system that prevents diversion and ensures adequate availability. This is not an or, this is and ensures. And drug control measures should not interfere with the medical access to opioids. How many of you feel that drug control measures don't interfere with access to opioids where you practice? Not many hands. Maybe you're all asleep. But this is again, and you can see the US has jumped quite dramatically. Canada is that little blue bubble just at the end, smaller population, but higher consumption than, not a line, but just that one in the top. My right-hand corner, your right-hand corner. WHO's brought out guidelines for children. This is very significant, and I like the term persisting pain. Not necessarily chronic, but this is for children with persisting pain. And some of the things that they're actually doing here, they've moved away or moving to a two-step ladder, and part of this has to do with codeine. Children under the age of 5 lacks the enzyme that breaks down codeine to morphine. Codeine is a prodrug. It gets broken down to morphine in the body. So it's a way of delivering low-dose morphine. It's interfered because it's cytochrome P452D6. There's all sorts of medicines that interact with it, but children lack the enzyme. And what's the most common opioid given to children in emergency rooms under the age of 5 in the United States? Codeine. Little point in using codeine, and I think we'll actually see that disappear from this spectrum. So while we had the United States, Germany, Australia increasing, we have other countries, and I have here Turkey in green at the bottom and Kenya, we have almost the rest of the world not having any opioid consumption whatsoever. So the reality is that 84% of the world's population consumes 10% of the world's morphine. 16% of us living in high-income countries consume 90% of the world's morphine. This is really an example of the haves. We can look at it through this graph, which I showed you before, with individual countries, and I've tweeted a link to our website so you can actually connect to this and look at the data. Or this is another way that the Global Access to Pain Relief Initiative showed it, which actually shows the countries by size of their opioid consumption. So the Caribbean sort of starts melting away there at the tip of Florida. South America doesn't exist, nor does Asia, and I'm not sure we can see Africa there. But really quite dramatic when you look at this graphically. We have other opioid consumption data, and this is using the program Gapminder, where you can actually look at the different countries, you can plot in your country and look at the overall morphine consumption, but clearly countries with lower income, lower human development index actually have very low consumption. Pain relief may be a luxury, but it shouldn't be. It should be a human right, as should palliative care. And here is again more examples looking at total opioid consumption and not just morphine with a combination of a number of medicines. This was an example after research we did. We showed that opioid consumption improved in Western Europe and no change in Eastern Europe whatsoever. So Nathan Cherney from the European Society of Medical Oncology and colleagues from the European Association of Palliative Care did a research study, and what they did was looked at opioid availability and cost. Complex side, you've got the countries along the y-axis, if you want to, going down. You have the medicines going across. If there's black, the medicine wasn't available. The color represents the cost. And while light blue is free, there's no such thing as a free lunch. It's at no cost to the patient is really what the label should say. And you can see Western Europe was pretty well covered. If we look at Eastern Europe, lots of black holes. And we even have countries where they had no immediate release morphine. And we have one country, the Ukraine, which only had injectable morphine available to these patients.
People in more than half the countries around the globe have limited access to medical morphine, and of that number, more than half face severe shortages of pain medication. Here in Ukraine, some of the same bureaucratic hurdles that plague India mean that even a former decorated KGB colonel is left to die in pain. Artur Shumanov has stage 4 prostate cancer, and is living out the end of his life alone and suffering.
Ой, я кричу ночью здесь.
It got so bad, he says, he's left his family in Kiev and moved to this cottage in a remote village hours from the capital.
Я не хочу, чтобы они видели, как я плачу. От боли.
The undertreatment of pain is a huge, huge issue. In Ukraine, pain is part of life. We can see the mark what the radiotherapy was given.
We invited Dr. James Cleary, a leading authority on global palliative care, to join us of the scope of the problem here.
Because of his pain, he's cut himself off from his family. What greater time is there for a man to need his family than when he's facing advanced disease? But what did he say? He didn't want them to see him cry.
Artur has found his own way to numb his agony.
И так каждый день бутылка.
And if it gets bad enough, Artur showed us his other plan to stop the pain.
Я чтобы застрелиться, когда будет сильно больно.
To watch Arturo reach under his pillow as he's talking about potentially ending his own life and then just pulling out this gun. This is not a gun in a cupboard. This is a gun that he sleeps on. So clearly the impact of this severe pain is great if he's that close most of the time. Artur died 3 months after our visit, unfortunately not at the hand of a gun or from his hand in the gun. He actually died peacefully of his prostate cancer. He was actually getting morphine from an illicit source. There was diversion. But there was a man prepared to do that in order to make sure he got pain relief. How many of you would be prepared to break the law to reduce someone's suffering? I'm not. And that's a significant issue as we move forward. How do we ensure access? And the rest of that video is available, and I've tweeted a link to the rest of that video as well. But Russia's actually had a number of high-powered admirals die at their own hand because of lack of pain relief. And the government's actually brought about changes in opioid availability there. So as we look at the different countries and their availability of palliative care, we went on and did a further study with looking at different regions of the world, including Latin America and Caribbean, the Middle East. And this is part of work that we've done through the formation of a Caribbean Regional Palliative Care Association. Cayman Islands was represented there, and we had the Minister of Health from Jamaica actually there in February of this year in a significant reporting and saying we need to improve palliative care in the Caribbean. And what we've done in this study is look at the formulary and cost issues related to these medicines, codeine, morphine, in different formulations, and then adding in oxycodone, methadone, and fentanyl. I'm going to show you the Caribbean and South American data. Unfortunately, we did not get survey returns for Cayman Islands, but you can actually see that Jamaica, Trinidad, Tobago, Barbados in general have these medicines available. Less so, Dominican Republic has it, but really the rest of the countries are then South American or Central American countries. And this is then reporting on the actual availability. So while they say they're on formulary, how often are they available? And if we look at Jamaica, codeine, half the time, yes, for morphine, it's usually, but there's actually not situations, or there's a few situations where people say it's absolutely available always. So there's one thing worse than actually not having the opioids available. It's starting someone on the opioids and having a stock out and having people go through withdrawal. There are policies that we've looked at overall in terms of are there restrictions? So we can see here Jamaica does not have restrictions on prescribing, but Trinidad and Tobago, you need special authorization as a physician to prescribe opioids. So we've been examining these different barriers, but this was a summary of the Caribbean and Latin America, South America, and we can see that the Caribbean, in terms of regulatory barriers, doesn't do too badly. But the Caribbean in general has very low opioid consumption. This is showing that same thing graphically across on a map. This is data from the International Narcotic Control Board, which uses a term defined daily doses. We can see North America uses well over 25,000, a lot. We can see that anything under 200 is inadequate, and anything under 100 is grossly inadequate. And Central of America and the Caribbean comes in the grossly inadequate as defined by the International Narcotic Control Board. We are not using enough opioids in the Caribbean for cancer pain management. I'm going to show you your data, and this is again available from the International Narcotic Control Board, and this is on our website. You may not be aware that your competent authority is the Chief Medical Officer through the Pharmacy Board, and that's the person who reports this. It's actually good that it's in the Pharmacy Board. Some competent authorities in some countries reside in the police department, which tends to make sure patients don't get access to opioids. But this is the Cayman Islands data. The pink line is the total morphine equivalence, blue is fentanyl, green is oxycodone, red is morphine, brown is pethidine, and blue is hydromorphone. And we can look, and this is, I'm going to show you even more detail now. This is your morphine consumption, which is getting up above the 10 milligrams per person per year. And the Caribbean data shows, and small graphs, but in actual fact, North America and Canada tend to make this data difficult to see because we use so much morphine. But in actual fact, most of the Caribbean falls below the global mean in the region. The red line is the regional mean. If we look at hydromorphone, yes, you're consuming some amount of that, 1 milligram per person per year, and this is the, again, the regional data. Very few countries have hydromorphone. So you're well off here. You have different choices and availability for patients. This is oxycodone consumption, and we can see you're consuming about 15 milligrams of oxycodone per year. And there's a little gap from 2013. Someone forgot to report to Vienna in 2013. They'll catch up, but someone didn't push the submit button on the computer, and that's why 2013 doesn't come up there. And the Caymans doesn't always appear on these 2013 data for that reason. But again, you can see that most of the region, the Caymans would fit in just at probably coming in third there in terms of oxycodone consumption as it works. And then here is fentanyl consumption, 0.4 milligrams in 2012. And if we look at that, you are above the global mean, the regional mean at 0.4 there, again coming in third. So the Caymans is actually doing very, very well in terms of availability of opioids. But does that mean that we're treating patients appropriately? There are many, many barriers to the appropriate access or to opioids, and some of these are physician not knowing how to use them, concerns about addiction still, and particularly with the war on drugs, cost may be an issue, a feeling that I may actually get prosecuted if I give people opioids. We have very little evidence that patients who are approaching the end of life have problems with opioid dependency, addiction. But we still see people saying, I don't want them to be on opioids because I'm worried that they will get addicted. This is the overall regional consumption of the different opioids for morphine equivalents. And here in the dark blue line, we actually have the AMRO region, so that's Latin America, the Caribbean, South America, without North America in there. And it still shows that that consumption is relatively low overall. And to some extent, the Caymans is inflating that because of your relatively good consumption. But we need to be moving to this model in order to bring about this significant change. And I think it is significant we need to be preparing. We need to be talking about where we are going overall. And one of the issues I want to raise is hope. We so much put hope in a plastic bag or a radiotherapy machine, a surgical oncologist. And this is a story from the New York Times, hope at $4,200 a dose. What is hope? James Tolsky, and again I've tweeted this link, wrote a lovely paper, Hope or Hubris. Is it the first definition, trust and reliance, but most of us use this hope in the context of expectations. I hope to see my grandchildren graduate from college. How old are they? 2 and 4. And you have metastatic breast cancer. That's maybe, it might be a wish. But James actually writes that it's difficult to practice medicine, cancer care in particular, but even other cardiac care, with this whole hope as an expectation. And he writes on the importance of hope as trust and reliance. A hopeful person trusts that whatever the outcome, good or bad on first glance, will ultimately be for the best. And one of the most hope-filled gentlemen I've ever met was a friend. We're out bike riding. He saw me on my bike going the other way and he turned around and came back. His wife was dying of ovarian cancer. And we got up to 25 miles an hour and I could hardly breathe, but he's still talking. And he said, you know, Jim, this sucks. But you know what? Things are going to work out. He was a hope-filled gentleman. And his kids have grown up now. He's remarried. It's not the vision he expected, but things have worked out. So I think trust and reliance is a very significant thing that we need to talk about. And from Robert Frost, hope does not lie in a way out, but in a way through. Let's come back to this woman, Mrs. MB. This was actually President Obama's grandmother. And many of you may actually be aware that she actually died just before he was elected president. But the president has called on us, and what I heard yesterday, and particularly in our workshop, is that we as a society have to have this discussion. We need to think about where we're going, and in actual fact, we as a society, and I ask you as the Society of the Cayman Islands, we need to talk and start addressing this concept of healthy dying. Thank you very much indeed.
Dr. Cleary, thank you so much for that very informative and thought-provoking presentation. Small token of our appreciation.